YouTube. Looks good. I'm seeing live on YouTube now.
Great.
You say yes, we're live.
YouTube. Looks good. I'm seeing live on YouTube now.
Great.
You say yes, we're live.
Great. Welcome, everyone. We'll just give people another minute or two to trickle in. Welcome, everyone. We'll just give people one more minute to trickle in before we get started. Okay, I think we'll go ahead and get started. Welcome, everyone. Welcome to today's webinar event, Women in Health in the COVID-19 Era. This event is co-sponsored today by Purdue University's Department of Public Health and the College of Health and Human Sciences, the Women's Global Health Institute, and the Women's Gender and Sexuality Studies program in the School of Interdisciplinary Studies. Just a few housekeeping items. Please note that your camera and microphone are disabled during the event, so please use the Q&A box to submit any questions. You can do so throughout the talk and we'll address them at the end. The chat is also disabled, so remember to use the Q&A box. And we're just so thrilled and honored today to have with us Dr. Anna Langer. Dr. Langer is the director of the Women in Health Initiative at the Harvard School of Public Health and a professor of public health practice in the Department of Global Health and Population. Dr. Langer is a physician specializing in pediatrics and neonatology and a reproductive health expert. She has conducted research in low and middle income countries and published extensively on maternal health, unsafe abortion, contraception, strategies to improve quality of reproductive health care, integration of maternal and newborn health care, and maternal health in humanitarian settings. In 2015, Dr. Langer chaired the Lancet Commission on Women in Health and published the seminal report, Women in Health, the Key for Sustainable Development, about a novel concept that looks at women's health during the life course, the roles women play as healthcare givers, and the inextricable links between these two dimensions. I'm actually just going to add that link in the chat right now for those of you who may be interested in checking that out. And without further ado, I'd like to welcome Dr. Langer. Thank you for being here.
Thank you so much, Natalia. Can you see me and hear me well? Okay. Can you see me and hear me well?
Yes, we can, Dr. Langer.
Yes, I'm sorry.
Wonderful.
I was muted. Yes, we can see you.
Thank you so much. Well, thanks to Purdue University for hosting me, and in particular for the multiple organizations at the university that host this seminar series. It's a pleasure and an honor for me to be here. My special thanks go to Natalia Rodriguez, who I met maybe 4 or 5 years ago when she was a student at Harvard. It's wonderful to be in touch again now in this new capacity. I'm really sorry not to be with you in person. I was very much looking forward to this opportunity to visit your wonderful campus and your beautiful setting. But unfortunately, the pandemic is making that impossible at this point, but hopefully soon we will have new opportunities. So as Natalia was mentioning in her kind introduction, women and health is the focus of our program. And the whole concept that I'm going to describe to you today got like a new urgency in the COVID-19 era. Let me show you the outline of my presentation. Next one, please, Natalia. So I'm planning to spend 30 to 35 minutes discussing women and health, the concept and overview of what we mean by women and health, and also what COVID-19, what does it mean for women and health? What are the changes and new challenges that the COVID-19 pandemic represents? And I will finish my presentation with some key recommendations for the advancement of the Women and Health agenda, and we will have time for a Q&A. So very quickly, what do we mean by women and health? And in fact, Natalia briefly described it very accurately. We go beyond the concept of the health of women and look at the many ways in which women and health are connected. When I mention the name women and health, I often emphasize that the word "and" is critical, because what we look at is at the interconnections between women as users of the health system, but also women as providers of healthcare, as I'm going to explain in a few minutes. And you already heard about the report where we describe at length the concept, and we provide a lot of evidence base for what we propose in that report. Next one, please. So in the same publication, we propose a conceptual framework that I'm showing on this slide that basically proposes that in the context of very dramatic economic, environmental, social, and demographic transitions, the health of women nowadays is changing rapidly as their roles as healthcare givers. And in fact, the transitions that we mention and analyze in detail in the report are very much the engine behind a very rapid epidemiologic transition that in fact represents an overlap between, if you will, old problems, sexual and reproductive health problems, nutrition, and infectious diseases, and a new epidemic of non-communicable diseases that is affecting women increasingly in all settings, developed and developing. Obviously, the epidemiologic transition became more complex now that we have a pandemic underway, and infectious diseases got a new prominence. Obviously, we are we are definitely not able to control infectious diseases as we thought we were. So health systems are often unresponsive to the multiple needs that women have, in spite of the fact that women are such core element of the health workforce and play such a significant roles at home and in the community in terms of healthcare activities. The roles that women play as healthcare givers are also affected by these same transitions. And a central principle that we have when we discuss the women in health concept is that If you look at the two large green arrows on both sides of the slide, because of persistent gender inequality, violations to women's human rights, in particular, in this case, the right to healthcare, and because of pervasive social injustice in many settings, human development or the opportunities women have to fulfill their potential are deeply affected, and the culture very often doesn't provide the kind of environment that would help women thrive. So the two circles in the middle represent what we often refer to as the two pillars of the women in health concept, the health of women and women as healthcare givers. So let me start with the first pillar, the health of women. For that, we adopt a life course approach. The next one, Natalia, please. So we look at women's health as a continuum from the womb to the time of death for women, and we recognize that women and girls have special needs, both biological and social, throughout their lifetime. And well, socioeconomic status and gender play special important roles in determining the health of women through the lifespan. Second, we also emphasize that each state, the health status at each stage of a woman's life influences the health status of the following stages, and sometimes even the health status of the next generation. Just to give you an example of that, if a woman, if a girl is malnourished in childhood, she will probably have complications during childbirth that will affect the fetus or a newborn. Also, if the woman has, or the girl and the woman have access to good health care at early stages of the life course, that will also improve the chances to have a good health during later in life. And a good example of that is the HPV, human papillomavirus vaccine. If a girl at 9 gets the vaccine, she will not be at risk of developing cervical cancer much later in life. So whatever access she had to good health care at an early stage of her life will contribute to good health in further stages of her lifespan. But not all phases or conditions are getting the same kind of attention when we talk about public health, when we think about public health or global health. And very often, well, the health of women is mostly limited to sexual and reproductive health, and well, other conditions that are equally important for women and are in fact becoming more important than only 20 years ago, don't get the kind of attention they deserve. The next one, please. So to illustrate that point, if we look at the causes of death among women all ages, the differences, the changes that happened between 1990 and 2017, we will see some important differences that have happened over the course of those almost 30 years. Well, this graph comes from the Global Burden of Disease study, and they have many data that you can look at in the Institute of Health Metrics and Evaluation website or the Global Burden of Disease website. I'm just using this one as an example. So if you look at the right column, the one that represents causes of death in 2017, you will see that non-communicable diseases now occupy the first 4 top causes of death. That might change with the COVID-19 epidemic, we don't know yet. If you look at respiratory infections, tuberculosis, it went from place 3 in 1990 as a cause of death to place 6. So it changed the importance, comparative importance of weight of respiratory infections and TB was reduced over that time, 27 years. Again, we don't know if COVID will change that situation or not. Enteric infections is another example. It went from place 6 to 9. Maternal and neonatal causes, that's very much the field in which we do most of our work, went from place 4 to 7. in terms of cause of death, which reflects the important progress we've made in improving maternal health, we as a global community. And of course, there are increases in neurological disorders and diabetes. Again, how will the COVID-19 pandemic change the burden of disease of women? We don't know yet, and we are trying to understand that. So if we go to the next one, this is an interesting comparison between COVID-19 rates, the differences between women and men. And the analysis of these differences has received a lot of attention lately. So if you look at this graph, for every 10 women who get infected, there are 11 men who get infected. So the difference is not that striking in terms of infection. The differences become much more important when we start looking at other indicators of basically indicators of severity. So if we look at hospitalizations, we start to see that discrepancy increase. So for every 10 hospitalizations among women, there are 12 among men. For every 10 admissions to ICU, there are 18 among men. And if you look at deaths, for every 10 deaths among women, there are 14 among men. So that means that, well, men are more severely affected by the COVID-19 pandemic. And that's different from other conditions that, that make women more vulnerable to severe disease and death. This graph that I showed before comes also from an interesting website for those of you interested in looking at this data that is called Gender 50/50. And it represents the situation globally, but the next, please. If we look at statistics that come from specific countries, in this case, I'm using Mexico as an example, you see a similar behavior of the disease. So I am not going to describe this slide in detail because basically it represents the same thing the previous one represented. So what explains these differences? Is it gender or sex or both, or a combination of both? You are now looking at a slide that simply represents the many publications that that are now in the literature about sex, gender, and COVID-19. And well, I encourage you to look at them in detail. You'll find many in different journals. In particular, The Lancet, JAMA, and other journals are extensively publishing about well, the influence of sex, gender, and gender on COVID-19. But obviously, sex and gender are not the only factors. If you can go to the what you are in the, yeah, this is the slide I need now. Obviously, sex and gender. Sex is the biological variable that determines if we are male or female and allows sexual reproduction, while gender refers to the social contracts, to the expectations, roles, and well, what societies see as normal in women or in men. And well, these two variables, both sex and gender, don't operate in isolation. They are a part of a number of other, they interact with a number of other variables, like the ones you see listed on this slide: socioeconomic status, race, ethnicity, housing, employment, migration, geographic location. And the combined effects of all these social determinants of health is what determines the severity of a disease, COVID-19, and everything else, basically. So it's important to have the intersectionality concept in mind when we look, when we try to understand what are the influences that determine the levels and trends of particular conditions. But let's look now more specifically to what COVID-19 is doing to the health of women, the first pillar of the Women and Health Initiative. The next one, please. So there are still many, many knowledge gaps in terms of what COVID-19 does to women, but there are, well, some pieces of evidence that are making the picture clearer. So there are now some studies, some publications that have shown that COVID positive women, women with the disease produced by the SARS-CoV-2 virus, have a higher risk of maternal morbidity and mortality, and also have more severe symptomatology of COVID-19 than the COVID negative pregnant women. Another effect that we are seeing in terms of maternal and maternal health, and in this case, maternal health care, is that because there are many policies and institutional protocols that are not really evidence-based, the women are now are being subjected to interventions that are not medically indicated, that are not necessary, really. We see that in many places there is an increase in the rates of cesarean sections, forceps delivery, and other types of instrumental delivery, that women are not allowed to have a companion during labor and childbirth. And even in some places, women are separated from their newborns. And breastfeeding is, well, not encouraged. Despite the fact that there is no evidence about, no conclusive evidence at least, about vertical transmission of the virus between the mother and the fetus or the newborn. Some complications, perinatal complications, have been documented. Higher risk of stillbirth and prematurity have been documented in some studies, although some of you may have seen some unexpected studies that also show that the prematurity rate during the COVID pandemic has decreased, and there are, well, interesting hypotheses to explain that unexpected finding, and we can discuss that during the Q&A if you are interested. Another effect that is an indirect effect, but a very important one that has been documented, is the increase in domestic violence due to lockdown, due to stress, due to higher consumption of alcohol. Women and children are being more exposed and are becoming more vulnerable to domestic violence. And there is this, well, in the words of the UN Secretary General, a horrific surge of domestic violence during the pandemic. Mental health conditions have also been documented, in particular stress, anxiety, depression, and there are some studies that show that suicidal thoughts are increasing both among men and women, of course. But as I was saying at the beginning of this presentation, women are not only the users of health systems, they are also critical sources of healthcare, both informally and formally. And let me say a few words about how we see that in the Women in Health program and in the work we do in general, and then zoom in on the changes that can be, well, that are due to the pandemic. The next one, please. So women as sources of healthcare, women are essential elements of healthcare at home and in the community, and obviously as members of the health workforce. And they are also becoming more important players in terms of policy making. And let me tell you in a few minutes what I mean by that. So starting with women as domestic healthcare providers. The next one, please. In most societies, developed and developing, caregiving is seen as a normal part of women's domestic roles. It's given for granted. Girls and women provide care to children, to elderly relatives, to acutely and chronically ill people living in their household, and to people who are disabled or dying. Obviously, under what the epidemiologic transition is making that burden heavier because, well, people live with chronic conditions for many years, and the care of those members of the family usually falls on women. Despite that critical role, well, what we see almost everywhere, although there are some interesting exceptions, domestic healthcare providers are not trained. They are not remunerated. They are not even recognized as people playing a special role, and in fact, to some extent, subsidizing the health system. Obviously, playing these roles put opportunities for education and generation of income at risk. And sometimes girls' schooling is interrupted because of these tasks that they have to undertake at home. And in the case of women, it means that very often they cannot generate an independent income themselves. The next one, please. Community health workers who play such a critical role, particularly when it comes to people who live in remote areas and people who don't have easy access to the health system, are overwhelmingly female. Just to give an example, this beautiful photo comes from Guatemala, a country in my region, as you may have. You may notice from my accent that I come from Latin America. So I worked for many years in Guatemala, and this photo represents a group of midwives in a remote Mayan community, and that's not an exception. I mean, you can see the same type of composition of community health workforces in Pakistan, for instance, where they have the lady health workers program that is, it's only that only enrolls women, and another similar program in Ethiopia called the Health Extension Workers that is also only women. So community health workers do not always get a salary or a stipend, and when they do, it's very small. And again, somehow it's given for granted that this is a role that women will play. And very often they are not well connected with higher levels of the health system. So if a referral is needed or support from a higher level of the health system, they don't have easy access to that. So the next one, please. In the formal health workforce, women are a majority. Nurses are mostly women. They comprise 80% of the health workforce globally. An estimate of the number of nurses and the number of people they care for is that 20 million nurses take care of 7 billion people. So this is amazing. It's a striking number, really. But female nurses earn less than male nurses, where in places where male nurses exist, that is not everywhere. And even in the same discipline, and are often not allowed to practice up to their full capacity. They are mostly seen as assistants to the medical doctors. And despite this, the fact that they are the dominant health workforce, they don't easily reach decision-making levels or leadership levels in their institutions. And next one, female, let's look at women as medical doctors. So in the medical profession, there is this trend towards women becoming the majority among among doctors. This graph comes from the OECD, so it only includes developed countries or developing high-level developing countries like Mexico and a few others. And it shows that male doctors are still more than 50% of the physicians in this list of countries. But that is rapidly changing, and women are becoming a majority in medical schools and in the early stages of their careers as doctors. But that changes progressively because, due to a lack of policies that should support women to integrate their family and professional roles and the social expectations around what is expected from women, female physicians are less likely to get into residency programs. They are less likely to practice full time. They are less likely to take leadership positions in clinical services. And there are also very important pay gaps between men and women. Men also outnumber women in academic medicine, as you may see in your own context. And just go back to the previous one for one more minute, please. And more women also face rates of sexual discrimination and sexual harassment, as it has been documented in several different places. So how is COVID-19 affecting the role that women play as healthcare providers? Let's look at the domestic level first. Yes, now the next one, please. This is an interesting graph that basically shows how some tasks are split between men and women at the household level. And these are tasks that, are associated with the health status of the family. Cooking and cleaning obviously have a strong effect on the health of children and all members of the family. So if you look at all kinds of couples, this data come from the US. Women now are responsible for 70% of cooking and cleaning in the household. And when both members of the couple work full-time remotely, they still play the most prominent role in terms of these tasks. And this becomes particularly obvious when when the couples have young children, children below 12 years of age. The next one, please. This is another similar example, homeschooling. Homeschooling is falling mostly on women in terms of the time they spend helping, supporting their children with that. This practice that is becoming now the norm during the COVID-19 era. So more than 80%, women help children with their homeschooling in more than 80% of the cases. The next one, please. What happens with women in the healthcare workforce? We already talked about the important proportion of women that are nurses and doctors that explains that women are disproportionately at risk of contracting infectious diseases in general and COVID-19 among them because they are a majority in the frontline healthcare force. Also because, and that a demonstration of that is that 73% of healthcare professionals who, got infected with COVID-19 were women, according to the CDC in April. Probably this number is now much higher. In addition to the risk of the infectious disease itself, that obviously represents a source of stress. And it can severely affect the mental health of women. The next one, please. Because I'm talking to an audience that is linked to an academic institution, I thought that you might be interested in this particular table that shows what has happened with women's authorship during the COVID-19 era, during the first months of the COVID-19 era. Again, this probably has changed even further in the same direction in the last 4 or 5 months. So this is a study that was published in JAMA that looked at the contributions of women to a journal, to JAMA surgery on papers that are not directly linked to COVID-19. But if you look at the column at the right of your slide, the last column, the absolute change, you can see that women as first authors declined by 4%. Women as last author or senior author declined by 6%, and corresponding author that is also a prominent position in a co-authorship list also declined by 7%. So this doesn't come as a surprise if we remember what we just described about the roles that women are playing at home. Obviously, they are not, they don't have the time, the energy, probably the concentration to keep working on their research project as much as they were doing before the pandemic. So there is one level at which women seem to be being much more effective than men, and that's the policy-making level. If you can go to the next one. This doesn't come from a scientific paper, it comes from a journalistic paper, but it's really, well, it describes interesting findings. There is growing evidence that female leaders are being more effective than men during the COVID era. And in fact, it had been demonstrated before COVID that women, whenever they are policymakers, they pay more attention to health and healthcare than men do. So in this case, you can see countries paired by population size, approximately population size, and more or less levels of development. And you can see that in countries that are led by women, well, the effectiveness in terms of controlling the pandemic, their effectiveness has been higher than in similar countries that are led by men. This is something that, well, would deserve a very rigorous study, and I hope that someone will conduct it soon, because it's really interesting and there are many hypotheses that could explain this difference. So going back now to the commission report, the Women and Health Commission report, and the work we did some years ago that we are now in the process of updating, let me tell you something about a study that was part of the commission work that we called the Global Valuing the Invaluable study. We did this study because we know that any data about money that you bring to the attention of policymakers will attract it. And we decided that instead of talking only conceptually about these discrepancies and inequities between men and women, we wanted to be able to provide numbers about what the underpaid, unpaid work of women represent in the countries where we were able to collect information from. So we call that study Global Valuing the Invaluable study. So, and the data come from a number of sources, from time use surveys, employment surveys, minimum wages data, and they come from 31 countries. So we estimated the full monetary value of women paid, under and unpaid contributions to healthcare, and also what the value was for each of these components. So the next one, the next slide, please, basically describes our findings from 5 years ago. And this study was led by my colleague Felicia Knoll, now at the University of Miami. Sorry. So if you look at the green box on top, well, $3.1 trillion was the size of the invisible subsidy that women give to society in the health sector, representing both paid and unpaid or underpaid work. And well, you can see the breakdown between paid and unpaid, almost well, equal 50% each. And we try to put this finding in context just to make it more well, easy to absorb to a general audience and to policymakers. And you can see some comparisons in the purple box. Well, this amount of money exceeds the total US and UK health budget. It represents almost 3 times the Mexican economy of that time. 20% of the US economy, and well, if we calculated how much each woman contributes to that full amount, and we came to the $1,200 figure per year. Okay, and as I said before, we are now in the process of updating this study, so we look forward to sharing our new findings with you. So let me just finish my presentation with some recommendations. We organized the recommendations in the Commission report in 4 buckets, and I am using the same ones, adapting them a little bit to the COVID-19 situation now. Then first one, next please. We called value women, and basically it means that in every country, everywhere, women should have universal access to healthcare. Men too, of course, but this particular commission was focused on women who are at a disadvantage compared to men almost in every dimension of their life. And not only that, we shouldn't only ensure universal access to healthcare, but we are also proposing in the commission that in the commission report that healthcare needs to be responsive to gender and adopt a life course approach. Obviously, policies need to be gender responsive and have that in mind when they are developed and implemented. And that there should be gender parity in, in this case, I added in all pandemic related task forces, sorry, and decision-making bodies, sorry, at all levels. There are also some publications that are showing, that women are not being fairly represented in the decision-making bodies at the global and country level, regional level, when it comes to the COVID-19 pandemic, and they should. And that's something we are advocating for. The next bucket, compensate women. We recommend that studies like the one we conducted at the global level should be conducted at the country level to have this very powerful advocacy tool to bring more attention and resources towards women and their health. And obviously that men and women receive equal compensation for the same work they do in the health sector. The next one, count women. It's very important that every statistic we have that is health related is disaggregated by sex. That will give us a first glance at what difference may exist between men and women. And that's data that we should have for the health workforce and obviously for all health statistics. And I mentioned before that not all countries are disaggregating COVID-19 data by sex. So that's something that really should happen everywhere, and we strongly encourage it. And also that every research study should include female participants so the findings of those research projects are really applicable to women. And that's an issue when it comes to the COVID-19 vaccines that are currently being tested. And we can talk about that later if you're interested, in particular pregnant and breastfeeding women who are not included in most trials. And finally, we should be accountable to women. The global public health community and the UN agencies and other influential global bodies, we should develop and implement an accountability framework, identify indicators that will help us track how we are progressing in terms of gender equality and the health of women. And those mechanisms should be independent. So my last slide comes it's a quote from Michelle Bachelet. You may have heard that name before, who said in 2011, when she was the founding director of UN Women, women's strength, women's industry, women's wisdom are humankind's greatest untapped resource. Michelle Bachelet was the president of Chile 2 terms, and now she is the UN human rights representative working in the UN Secretary General office. So she's highly influential, and we very much support her agenda. So I think this is my last slide, and we still have some minutes for questions and answers. Thank you.
Thank you so much, Dr. Langer. I'm going to, well, maybe I'll leave the slides up in case we have any questions that you need to refer back to slides. We have a couple of questions in the Q&A, but I wanted to actually start with touching on one of your recommendations on counting women and the importance of disaggregated data. It seems to me like we don't really know how this pandemic, this particular virus, is affecting women. And I know that you mentioned, you know, there's significantly more deaths and severity of cases among men. But I guess I'm wondering if you think it's possible that women are not getting adequately tested, or if we don't have the right quality of data. We know even in the US, we weren't disaggregating data until almost June, I think. We also know in current vaccine trials, I think Moderna publicly said they were not going to be disaggregating data. So I guess I'm just wondering if you think there's any sort of exaggerated or amplification effect of the current trends we see based on that.
Thank you, Natalia. That's a great question. As I said before, there are still very, very important knowledge gaps. These are, well, what I summarized here are findings based on the limited data that we currently have. There are some reasons to believe that men are at higher risk of death and severe disease. And there are some hypotheses about why that would be the case. Some of them related to the role in society or their gender, and others biological. In terms of the biological factors, it could probably be related or a result of underlying conditions. Men smoke more, men drink more, men are in general in poorer health than women are, particularly at older ages. So that may explain in part the difference. And from a gender or occupational perspective, they are often more exposed to working in environments that may represent a risk for acquiring the infection. And well, there are other circumstances in the US that are affecting healthcare seeking, both among men and women, that should be analyzed, and particularly immigrant men and women. And well, there is so much to talk about. But what you mentioned as a possibility, yes, it's something that is being considered by many people working on these issues, that maybe, well, the women dying in poor communities, no, I wouldn't say in the US, but in some developing countries are not counted, that are not registered, and that women have more difficulty to get to healthcare institutions, and therefore they are not registered as patients. So all this could also influence our findings so far. And there are also some immunological and genetic hypotheses that could explain the differences between the men and women. But well, one obvious step, as you were saying, is that well, data should be disaggregated everywhere by sex, and they are not. They are still not. That's still not the case in all states in the U.S. And the vaccines issue, yeah, that's another important one. I mean, usually clinical trials or people in charge of clinical trials that are testing new drugs or vaccines are sort of reluctant about enrolling pregnant women and breastfeeding women because of the potential impact on the woman and the fetus or newborn. But they should definitely find a way to do it, because otherwise, how are the results of trials that are not enrolling women be applicable to women? So I know there are, well, important discussions happening about that. Same thing with children. They are not enrolling children. And so what are what recommendations will they come up with for vaccination among children? That's an issue.
Thank you. So moving over to this area of disproportionate burden of domestic work and unpaid domestic work, and we have a few questions related to this. The first, we know that, and there's been many articles out about the gender wage gap widening and women dropping out of the workforce at alarming rates right now. I'm curious how this looks different elsewhere in the world. Is any country doing this right? And are there Are there models that are worth looking into and following in terms of adequately supporting women during this time?
I mean, there are countries that are doing it better, but I wouldn't be able to point to any countries that have found or implemented a policy that would make the pay gaps disappear or narrow during the COVID-19 era. Even we are not seeing that even in the countries with the most progressive social policies, like the Scandinavian countries and other countries in Europe. I mean, this is a pervasive phenomenon, and I may be missing something, but I don't think there are any glaring examples of countries that are doing it really well.
That's disheartening. But on that note, one of the questions in the Q&A is, was the comparison for time spent homeschooling between men and women among all couples, or just among couples in which both work full-time, or in which both work full-time remotely? Do we know the details of that?
Well, yeah, if you go back to that slide, in fact, the slide disaggregates by those different circumstances. That's slide 17, if it's easier to find it that way. That one. So as you can see, the first couple of bars represent all couples, and then below that, couples where both members of the couple work full-time remotely, and the other one, couples with children under the age of 12. So the trend is consistent, the numbers change. And again, these numbers are just illustrative. They would probably be different if they did this study today. It came from a survey, but I think that the trends are so consistent that it's fair to believe that this is a true fact.
And on the same note, and maybe it's the next slide, or we'll go to that one, but regarding women as policymakers, is this truly an effect of the woman as a leader, or is it that societies that elect women leaders are also likely to do better or are more willing to take public health measures effectively?
Excellent point. Yes, who knows? This is, I think it's both. It's a very, very rough analysis of these differences, and some people are very, very excited about the differences, again, these trends that are starting to become apparent. But more rigorous studies are definitely needed to control for so many other confounding factors, among them the ones that are mentioned by the person who asked that question. I don't know. I don't know enough what's going on in these particular countries to have my own opinion, but I think that these studies should be more rigorous if we want to come to conclusions that are really solid.
So moving on to more of a controversial topic, I was wondering, you touched on this a little bit, the effects of the pandemic on family planning, but I was wondering if you could go into that a little more. We know in the US, for example, abortion was deemed a non-essential procedure. And is this unique to the US, or what can you say about global effects on family planning?
Yeah, thank you. That's a great question. There are some estimates. I don't remember the numbers now by heart. I don't have them in front of me, of the millions of unwanted, unplanned pregnancies that may result from the lockdowns and the difficulties that women are having in accessing reproductive health services, family planning among them. So that, the pandemic definitely will contribute to a lower contraceptive prevalence in the US and everywhere, because, people themselves don't feel comfortable going to health services, and also they have so many more challenges to move around and freely and go to the places they need to. And same thing with abortion services. There are some organizations that are doing some interesting experiments, more than experiments, pilot efforts that are not very large scale, but still very important, like the groups that are mailing medical abortion pills to women who request them, supporting them at the same time with telemedicine and consults with healthcare providers online. And more could be done in the US and elsewhere in terms of giving women better access to contraceptives. I mean, yeah, more contraceptives should become more available over the counter. Using the pills as an example, multiple cycles women should have access to multiple cycles of pills whenever they need to get them in a clinical settings instead of just pills for 1 month. And yeah, much more could be done about that. I don't think it's been adequately prioritized yet.
Moving on, there's a few questions in the chat, but everyone please feel free to continue to add them in here. For maternal and infant complications due to COVID-19, the medically unnecessary interventions, is there a difference in care depending on the gender or sex of the healthcare provider?
Oh, good question. I haven't seen anything published about that. I mean, that would be an amazing study. So whoever asked that question, I encourage him or her to consider it and at least write something about why that would be important. I think it would, for the Women and Health Initiative, it would be really interesting to look at that. But I don't know if the sex of the provider is recorded anywhere. But in any case, conceptually, it's a very interesting question. I don't know if it's feasible to answer it.
One of our reproductive health colleagues is asking if you've seen the data on breastfeeding and what that's looking like. Are we expected to see a decrease in breastfeeding due to lack of provider support, doulas, lactation consultants, fears of transmission with uncertain research on if COVID can be passed through breast milk, life and family stressors taking time, etc.? You seen any?
I mean, there are some studies that have quite conclusively demonstrated that the virus doesn't transmit through breast milk and that breastfeeding doesn't represent a risk for the newborn. Maybe there could be some traces of the virus if the mother is COVID positive in breast milk, but it's not I don't know, full viruses, and it doesn't infect the baby. So that's something that is very, very important to stress whenever someone is scared about breastfeeding. And there are some organizations, including organizations, the professional associations in the US that recommend that the mother takes certain precautions before and during breastfeeding to minimize even that small risk. But yeah, fear of transmission and some clinics, hospitals, providers that are offering non-evidence-based advice and plus, what you just said, what that person just said about the fewer women who are currently cared by doulas and breastfeeding, supporting people who support breastfeeding. Well, all of that might contribute to a decrease in breastfeeding, which is definitely not, the prevalence of breastfeeding is definitely not ideal now. So, and it might become even lower in the coming months, or hopefully it's just months until this situation improves significantly.
And one last question on my end is, you talked about this shift in burden. The focus has been so much on maternal and reproductive health among the women's health agenda, but we do see this rising burden of chronic diseases and cancer. With COVID-19, do we know yet, or have you seen data on the effects on things like women's cancer screening, vaccinations, all of that? Do we know what the long-term effects may be?
We really don't know. Obviously, the pandemic will have an effect because those are considered sometimes elective services and the healthcare providers and health institutions that are overwhelmed by the pandemic, and even users' reluctance to go to healthcare services represent barriers that we didn't have until this situation started. Yeah, I haven't seen any quantitative estimate of by how much those preventative or follow-up activities could decrease, but it's going to happen. I'm afraid.
Yeah, we'll have to see where the data takes us. So we have 1 more minute and way more questions than we have time for. I'll ask one last one, but I will say we will post our publichealth@purdue.edu email in the chat. So if you do have follow-up questions for Dr. Langer, please feel free to reach out and we will communicate those to her. In our last minute, with so much funding being shifted to COVID-related studies, do you have any concerns about the future of women's health research broadly?
Well, you asked very good questions and tough ones at that. Yeah. I mean, the funding for women's health studies is always limited, unfortunately. And even for COVID, the funding is limited. It's not easy to get funding these days for COVID-related work, except for very specific topics, critical ones, but still very specific, like vaccine development. So yeah, that might also be a longer term effect of the pandemic. We need, all of us need to be prepared to advocate for more attention and more resources for research on the health of women, research on gender and sex differences, and well, during the COVID-19 pandemic and beyond. So yeah, this is, I hate to finish this amazing exchange on a not so positive note, but yeah, that will probably be the case.
Well, thank you so much, Dr. Langer, for being with us. What an honor. And we will maybe have some follow-up questions for you that we'll send your way over email if that's okay. But with that, let's all thank Dr. Langer. We'll do a virtual round of applause. And thank you so much for being with us.
Thank you all for having me and for your interest in these topics.
Thank you all. This recording will be posted on the public health website for anyone who may be interested or missed a part of it. Thank you all.
Bye now. Take care.